So I want to just first thank everyone for attending this event. So late in the semester, I'm sure some of you are scrambling to kind of finish your finals and wrap up the semester. So thanks so much for joining us as part of our Dissemination and Implementation Science speaker series. I'm going to briefly introduce myself, the broader goal of the speaker series, and then our esteemed speaker. So my name is Brianna Last, and I'm an assistant professor in the clinical area of the psychology department at Stony Brook University. And this dissemination and implementation training series is part of a project that's been supported by the Academy of Psychological Clinical Science. And the overall goal of this project is to really strengthen dissemination and implementation science training across clinical psychology doctoral programs. As we know, population mental health challenges are rising and have become more pressing across the country and around the world. And there's a real need to ensure that people can easily access high-quality mental health services. The question of how to meet this need is one that dissemination and implementation scientists have really tried to answer. And the field has developed unique methods, theoretical frameworks, and models that can help move the needle on population mental health. However, training in dissemination and implementation science is not widely available in clinical psychology doctoral programs. And so we hope that by making the speaker series free and virtual, that we can support everyone who's interested in learning about dissemination and implementation science. So today's presentation, Transforming Mental Health Systems, features esteemed psychologist Dr. Arthur Evans. And I'm going to briefly introduce Dr. Evans before letting him take it away. So Dr. Arthur Evans is a clinical and community psychologist, chief executive officer, and executive vice president of the American Psychological Association. Before joining APA in March 2017, Dr. Evans spent 12 years as commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. In that post, he led the transformation of the agency's approach to serving a wide range of individuals with complex needs. He emphasized a data-driven population health approach to improve and expand behavioral health services for people. The work in Philadelphia has become a national and international model, with over 25 states and more than a dozen countries having either visited the city or invited Dr. Evans to speak about the Philadelphia model. Throughout his leadership, he employed science, research, community activism, spirituality, traditional clinical care, policy, and cross-system collaborations to change the status quo. His approach gave voice to and empowered individuals and communities that have been historically marginalized. He ensured those with lived experiences were involved with every policy decision. He enlisted political and community leaders, grassroots organizations, academic institutions, and advocates in a citywide commitment to think differently about behavioral health and intellectual disabilities. Prior to his work in Philadelphia, Dr. Evans was the Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services, where he led major strategic initiatives for the state's behavioral health care system. He was instrumental in implementing a recovery-oriented policy framework, addressing healthcare disparities and increasing the use of evidence-based practices, leading-edge research, and community engagement. Dr. Evans has been honored nationally and internationally for his work. I'm not going to list all the honors that I discovered, but they are numerous. And in addition, he has been an outspoken proponent of disseminating psychological science and mental health. And he's been featured in major media outlets such as the New York Times, the Washington Post, CNN, NBC Nightly News, The Today Show, and ABC News. So we're really honored to have Dr. Evans here. Just to give folks a sense of the structure of today's event, Dr. Evans is going to speak for about 30 to 45 minutes, and then we'll have a question and answer period. I'll start us off during the question and answer period with some of my own questions before opening it up to the audience. So feel free to hold your questions until the end. We'll definitely have lots of time to ask our esteemed speaker questions. And just for those of you to be aware, should you experience any technical difficulties or have any questions during the event, please write to either Madeline Papard or Laura Jans, who are waving, And they also are available via the chat. And if for whatever reason you get logged off, you can email the dissemination.implementation@gmail.com email, and someone will support you in getting back on the Zoom. And if you'd like to view the presentation with closed captions, you can click Show Captions on the bottom bar of your Zoom screen for increased accessibility. All right, without further ado, I'm going to let Dr. Evans take it away. Thanks again.
Thank you, Dr. Last, and thank you all for joining us today. I'm very honored to be asked to come, and I just think it is really neat that you all have this opportunity, because when I was in graduate school, we didn't have the kind of opportunity to talk about sort of real world application of knowledge from the field. And I think, so I just really impressed that you have so many people who are interested in that and this topic. Let's see, I hope you all can see my presentation. So if you can give me a thumbs up just to make sure that we're okay.
Yep.
Okay. All right, good. So delighted to be here. So what I want to do is talk about evidence-based practices. And I want to talk about it in the context of how do we get more of our field to embrace and use evidence-based practices. This is a big challenge for the field. If you are kind of paying attention to what is happening in the field, you know that there is limited spread of evidence-based practices in most public systems. I'm going to talk about this from a public system standpoint, that most public systems don't have a high penetration of evidence-based practice use within their systems. We also know that that the applicability of EBPs across different populations can be challenging and very spotty and sporadic. That EBP implementation is actually quite resource intensive, and there are lots of issues around sustainability, just to name a few of the challenges that we have. And since there's so many people who are in their training listening to this, I want to kind of get you to start thinking about 5-10 years out, and you're now responsible for a system like I was, or you're a researcher trying to really get things that we've learned from our science and research into the field. How do you do that? How do you actually make that happen? And so that's really what I want to focus on. And I want to start with, psychologists, I believe very strongly in having a good conceptual framework for any discussion that we're having. And I want to suggest to you that one of the challenges in the spread of EBPs is the mental model that we have for how we help people, and how that mental model constrains then how we think about the challenges of getting the spread and getting more endorsement and embrace of EBPs. And I want to suggest to you that most of us are trained with what I call a black box model, meaning that, did I stop the presentation? I didn't. Okay, hold on. Sorry, I just clicked on something that made it look like, okay, I can see it again. So most of us are trained with black box model. Basically, the way it works is this. People get sick, they come to us, we diagnose them, we figure out what's wrong, we treat what's wrong, and then people are discharged, and that is the way they derive the outcomes that they're seeking. Now, let me say up front that this model, this mental model, or this way that we approach behavioral health conditions is as effective as the treatment of any other chronic condition. So if you look at our outcomes in behavioral health, and I'm going to use behavioral health meaning substance use and mental health. If you look at our outcomes in behavioral health, they are comparable to the treatment of cardiovascular disease, of kidney disease, and any of those other kind of chronic conditions. So this is not a critique on our work per se. It is a critique on what are the limitations in the way we think about our work. If we had more time, I would spend a little time talking about all of the reasons why this is problematic. But let me just give you a few. One is that most people who have behavioral health conditions don't seek us out. So 10% of the people who have substance use conditions, 50% or less for people who have mental health conditions will ever actually reach out for help. So the first problem is the majority of people who have behavioral health conditions in any community, in the community that you're in, are living with those conditions and they're not seeking out help. And so our model then is a challenge because this is a passive model for conditions where we know we have to be more active in reaching out to people. We assume that when people leave us that they are, quote, fixed or cured. At least that's what the public believes. And we know that these are chronic conditions and that people's needs continue post treatment. We know that people who seek out treatment, if they seek out treatment, often have a very complex set of issues. So people who have substance use problems often have mental health challenges. They often have physical health challenges. They have lots of things. And if you go to a black box that is focused on your mental health issue and you really also have a substance issue that is driving that, those issues are going to be missed. You're going to be undertreated and you're not going to get the outcomes that you want. There are many challenges, but let me tell you how these challenges play out when it comes to EBPs. In the early days, we really focused on helping the clinicians to understand and be trained in an evidence-based practice. And what we figured out is that, particularly in public systems, is that if we train someone in an EBP, and you go back to that program 2 or 3 years later, you often see that the provider is no longer providing that because the clinician left. And so then we figured out, well, you just can't train the provider or the clinician. We also have to train and make sure that the organization is embracing the EBPs and has built capacity at the organizational level. That was a big shift, the conceptual shift that we made in the field. But I want to argue that even at the organizational level, if all of our work is at the organizational level and individual level, we still haven't done enough to sustain and implement EBPs. And the primary problem from my vantage point, especially as a mental health commissioner, was the focus has to be on the individual. So in the previous model, the focus really was on treatment and the treatment black box and trying to make sure that within that black box, we were doing everything that we could to provide evidence-informed, evidence-based care. But if we kind of flip that and said, let's think about the individual being at the center, right? That treatment is one of many things that people need in order to be successful. And that what we want to do is we want to make sure that this treatment black box or the treatment is really good, but we also need to think about the bigger context. And what we're really trying to do is create an evidence-based ecosystem so that people get all of the resources, services that they need to be successful. So that's the fundamental shift that I want you to think about, because for researchers, I get it. You know, my early training was in experimental psychology, so I get how important fidelity to the model is. I get how important it is to make sure that people are practicing the practice in a certain way. But at the end of the day, as a commissioner, what I really care about is whether people are getting well and whether we have created a system and an approach to make sure people are well. So let me just do a quick sort of recap of how our field has evolved. And back in the 80s, when I came into the field, I came in the field around 80s, early 90s. the way we thought about taking what we knew from our science and getting it into practice was we created toolkits. So if you went to the federal government, to SAMHSA, you would see toolkits. And the idea was that people were going to take these toolkits, use them to change practice. And we figured out pretty quickly that didn't happen. That wasn't going to work. And then we went to what we really have to do is we have to actually take that research and train clinicians directly on that research. And we figured out, as I mentioned, that that wasn't good enough. We actually had to work at the organizational level. And I think that's kind of where the field is right now, that we are focused on implementation science that is about changing organizations. And I think that, again, that is a huge development in our field. But I'm going to argue that what we really have to do is create evidence-based systems of care. And I'm going to talk about what that will look like. The backdrop is Philadelphia, a city of about 1.5 million people. We often, Philadelphia is often described as a city of eds and meds, great educational institutions there, but also a lot of really fine healthcare systems. But it is also a city that has some very significant challenges, as any major city in the U.S. or in the world has. When you have issues around homelessness, of poverty. Actually, Philadelphia is the poorest of the top 10 largest cities in the country. About 40% of the population is at or below the poverty line. So it gives you a sense of that. So even though there's a lot of wealth and a lot of people are highly educated, you also have this contrast with these major challenges. And so the challenge for us was, and for me when I was the commissioner there, was how do I take what I know as a scientist practitioner, as a as a someone who does research, but who's someone who has done clinical practice, take all of that knowledge and use that to get the outcomes that we want in a very diverse population, high immigrant population, high communities of color, lots of marginalized communities, particularly from a socioeconomic status. And what we did over the course of a decade, more than a decade, we were able to largely expand the number of EBPs. We were able to serve literally tens of thousands of people in evidence-based treatment approaches. We were able to get EBPs practice in essentially every level of care within the system, from outpatient to residential to substance use, mental health, for children, for adults, for people who were experiencing homelessness, to people who were experiencing serious mental illness. Across the entire system, we were able to infuse evidence-based treatment approaches. And let me say up front, still lots of work to do, but we were able to get the traction and to get the spread much more than probably we even anticipated. So I want to talk about some of the lessons learned in doing that. So here's the basic premise of my talk. It is that we didn't implement EBPs for fidelity's sake. What we did was to implement EBPs to improve people's lives. That is the central idea here. And I think if in our efforts we're focused on that, we can make a lot of progress in getting the kind of spread that we want and sustainability. Oh, okay. So here are the lessons learned. I'm going to go through these and try to highlight a few of, and these obviously is not all of the lessons learned, but a few of them that might be interesting. The first is that it is really important to do EBPs in a overarching philosophical framework. Now, I believe that every system has a philosophical framework. Often it is not articulated. And one of the reasons I always talk about the black box is I want to make apparent a lot of the underlying assumptions that go unspoken, right? And so the unspoken philosophy is a medical model, treat pathology framework. What we did in Philadelphia, beginning in 2004, when I arrived in the city, is to make an intentional effort to shift to a recovery orientation, recovery and resilience, resilience for children, recovery for adults. And simply what that meant is that our outcomes that we were wanting to get, and we wanted to redesign our system to get, were long-term recovery for individuals. So for people who had serious mental illness, our outcome wasn't that just that we would reduce symptoms, although that's important, but we wanted to go a step further so that people were actually living the kind of life that they would want to live. This is a picture of individuals who were part of programs that were focused on historically people going to those programs. They would be in those programs all day. They would go home, come back the next day. They would be in the programs all day. And literally for years, we call them day treatment programs. People would be in these programs. And so when we took on this idea that we wanted to shift to recovery orientation, we started to do things like coach people on how to use public transportation. It's coaching people on how to get into school, to start a business. Because the goals that we wanted to have with people is not for people to come to our programs and to be asymptomatic, but our goals were to help them have the kind of life that they wanted to have. So that overarching framework of recovery as the outcome was the framework that we were working on in 2004, 2005. Um, and um, one of the things that we did in developing that framework is to clearly articulate where evidence-based practices fit. That was important because this was the early 2000s, so the recovery movement in the US was just starting. There were people in the recovery movement who said that evidence-based practices were antithetical to recovery, because in a recovery-oriented system where you're working collaboratively with the individual, not in a hierarchical way, where people have voice about what it is that they wanted to work on and what their goals were, that in that kind of system, evidence-based practices were too rigid and would not be the choice of individuals. I believed as a psychologist that if we had a movement that didn't incorporate the best science, that we were not going to get the best results. And so we were very intentional early on to say that from our vantage point, we cannot help people recover, have the kind of life that they want to have, if we're not using the best science to aid us in helping that. That was really important because opportunity knocked. In my first year there, this is Aaron Beck, called me up and said, this conversation, we know that CBT works, but CBT is not widely practiced. You have, your new commissioner, you have the system, know you're trying to change the system. Could we work together to get more evidence-based practices practiced in our system? And I said, Aaron, who are you? No, I didn't. Obviously, I was like, absolutely, we could do that. And that started a partnership that really lasted until we called him Tim. Tim Beck died, a couple of years ago. So in that partnership, what we decided early on was that we would implement EBPs as one of our main strategies to help people to recover from whatever it was that they were dealing with. And in the early days, we put a lot of emphasis, as I said, in our, and sort of talking about the evolution of EBPs, on training clinicians. And over the course of the time that we worked with Tim and his group, we were really able to expand EBPs across lots of different levels of all of the different levels of care. Lots of clinicians, hundreds, thousands of people got access to those, but not just CBT. We work with Marsha Linehan in terms of DBT, Judy Cohen in terms of TFCBT, Edna Foa in terms of prolonged exposure. The point is, once we open that door to say, we believe that this science, this research can actually help improve outcomes, then we started to look around at all of the EBPs that we thought would be important in implementing to get us those outcomes. Let me give you one example of that. Probably this work came later in our work, towards the end of my tenure, where we started to look at a level of care called extended acute inpatient units. And the extended acute inpatient units, when the state hospitals closed, um, the city had a challenge, right? So historically, when someone had an acute admission to an acute care unit, didn't get better after 2 or 3 weeks, you wouldn't leave them there. You would send them to a state hospital for longer term acute care. Well, when the state hospitals closed, we couldn't do that. So what the city did, this happened before I got there, was they created this level of care. And it was for people who were really having a difficult time. They just weren't improving um, in traditional acute episode of care. And so these are the folks in the system who really were the most complicated, had the most challenging clinical presentations. I won't go into describing some of the behaviors, but for those of you who work with people with very serious mental illnesses, you can imagine how challenging some of the behaviors were. And what happened over time was, because these units were doing essentially the same thing that traditional units did, was we started to get very long lengths of stay. So people were staying 6 months, sometimes up to a year in these units. Most of what was happening was just trying to manage behavior, not a lot going on therapeutically. So Dr. Beck and his group said, let's take on this. And for those of you who may not be familiar with the research in this area, there's actually a lot of research that shows that you can use cognitive therapy to reduce, actually effectively treat psychotic conditions. So a lot of that work has been done in England and Britain, but not so much here. But we knew the research and we knew that it could be quite effective, but we implemented it from a recovery standpoint. So what that meant was that rather than just uh, focusing on treating symptoms, reducing symptoms, the way the practice was implemented was to essentially ask people, what is it that you want to work on? And there's some great stories we can talk about during the Q&A, but suffice it to say that the that approach actually was quite effective. And in fact, here are some of the outcomes. We were able to reduce the length of stay to half, and these programs cost at the time probably around $600-700 a day. Cutting that in half, if someone has a length of stay of a year, we're literally saving tens of thousands of dollars, but hundreds of thousands of dollars. We were able to reduce assaults by 60%, reduce the use of restraints and seclusion, reduce the need for IM medication, but most importantly, because we were also training the people in the community on this approach, we were able to get people out of the units and into a community program that was using a similar approach. So very effective strategy, but the key ingredient was doing that work from a recovery orientation. And what Tim would say is that, look, we knew that we had the research and we had the data that the practice was effective, but it was much more effective when we used recovery orientation. And for those of you who are interested in working with people with serious mental illness, I would, Tim wrote a book called Recovery Oriented Cognitive Therapy, and it really details a lot of the strategies that we used here, and then later that Tim and his group used across the country in similar kinds of situations. Second lesson learned is this idea of taking a systems perspective, and I wanted to give you three examples of that. I want to contrast that to the black box strategy of focusing solely on the treatment, but really thinking systemically. And I want to use three examples. Homelessness, big problem. Every city, most people will say, the reason we have homelessness, and in fact, literally today, I was on a call with someone and we were talking about homelessness. And this person said, the reason we have homelessness is because we closed the state hospitals and all of those people are now on the streets. Turns out that that's not true. First of all, many of the people who are on the streets were never ever in a state hospital, and many of them would never ever even be eligible for a state hospital. The people who live on the streets are on the streets for one reason only, and that is they don't have a place to live. And if you solve that problem, guess what? You no longer have homelessness. Um, so, how do you take on this problem, which is endemic across the country? Every major city that I've ever been to anywhere in the world has people who are homeless. Most of them in American cities are people who have mental health challenges, substance use challenges, or both. Some of those conditions develop after people become homeless. So it's not that their conditions are driving homelessness, but they then develop these conditions. Historically, what we would do is, we would create a program, figure out the program, get people to try to come to the program. And most of those programs actually don't work for a whole variety of reasons that I won't go in today. But what we did is because we wanted to take an evidence informed approach is we used the research and evidence to drive all of the decisions that we made. The key ingredient was that we were able, the mayor negotiated 200 Section 8 housing vouchers per year, specifically for people who are homeless. And so we weren't just looking at how do we address their mental health needs, but we had attached to that vouchers where we could get people into community housing if they were a part of the program. So how do we do that? One of the first things that we did was to, when you look at the research, what we know is different things work for different people. If you look at stages of change research, for example, one of the things we know is that people are at different stages of change. And if we have one route to help people, we're going to miss that nuance. So that's an evidence informed understanding. And what came out of that is that we created multiple pathways out of homelessness. So one pathway was harm reduction because we knew some people were just not ready to engage in the system. One pathway was for people who had long-term chronic substance use challenges, which involved a very long length of stay residential program. One pathway was for people who had serious mental illness using a housing first strategy. And housing first is a strategy that has lots of evidence, quite effective. So rather than trying to get people into a program, getting them, quote, stable, and then moving them to housing, what you do is you work with people, you get them directly off of the streets into housing, and then you support them in housing with specialized case management, right? So what the research said is that that is a much more effective strategy in engaging people with serious mental illnesses than sort of the traditional get them in treatment and then try to move them into housing. So we created those three pathways, all informed by science and research. And here's what the data looks like. So I'm going to kind of explain this. Each of these sort of these group of bars here is a different pathway. So this is safe havens. That was our harm reduction pathway. This is the pathway for people who had very serious substance use problems. This was the pathway for people with serious mental illnesses. And what I want you to see here, so this is financial data, right? So the three bars that you see here, the light blue, the yellow, and then the blue, are the 3 years before people were housed. And so what this tells us is that for people who were using that harm reduction pathway, it was costing us on average 3 years out before the person was housed about $85 a day. We engage the individuals, the costs go up $97, $112. But look what happens in the year that people are housed. That's the gray bar here. The cost per person per day goes to $18 a day. We saved hundreds of thousands of dollars. And when we started this, we believed erroneously that people who were homeless were not costing us much because they're not engaged. Well, it turns out they were costing us hundreds of thousands of dollars because they were going to emergency departments, they were getting admitted to programs, but there was no real coordination of their care or anything. And so the costs were quite high. And we can see that as we engaged them, those costs went up. But the moment we got them into housing, those costs dropped to, $18 a day. And you can see that roughly that pattern with all of these individuals that engaging folks and then getting them into housing was a very effective strategy. We also know in cities like Philadelphia, you have lots of people who are exposed to trauma. And if you are familiar with the ACEs study, we know that most people, most communities, whether you're middle class or working class or whatever, are exposed to trauma, and that exposure to trauma and adverse events can lead to more significant challenges. In Philadelphia, I mentioned earlier that did we created evidence-based treatment programs on lots of different levels of care, lots of different EBPs. This is a map of the city. All of these dots are evidence-based treatment programs, and in this case, it's TFCBT, trauma-focused CBT, and another evidence-based practice developed by some colleagues at Yale, CFTSI, which is a practice where if a child is exposed to a traumatic event and they're given this intervention within a certain window, it actually dramatically reduces the likelihood that the child will develop traumatic stress as a result. So these programs are spread throughout the city. And you could say, okay, that's great. Hopefully the kids get there. But what we also were able to do through a federal grant is to screen children in pediatric settings, in primary care pediatric settings and other pediatric settings where kids were going. When I left the city in 2017, we had screened about 30,000 children. About a third of them screened positive, and we were able then to connect them to an evidence-based treatment approach. So here's the thing: we could have simply trained those providers, got them trained, but the real ingredient to making that EBP work was adding this element of screening and referral and getting people connected to the right level of care and the right treatment that is based in science. And so if you work with older, older people, adults, one of the things is that many of the people who are experiencing substance use and mental health challenges as adults had early childhood traumas that were never addressed. And so this is a way of addressing that. And then one other example, in most states you see very high levels of residential use or use of residential care for children in the child protection system. And in many states, like both when I was in Connecticut and when I was in Philadelphia, lots of that treatment is outside of the state, outside of the communities that these kids live in, which we know as psychologists is re-traumatizing. Anytime you take a child, even if a child is in an abusive situation, when you separate that child from their parents and from their family, it is a traumatic event. We were literally sending kids as far away as Utah to not only a large distance where you couldn't do any family work, but to communities that were just not um, uh, accustomed to working with kids from, inner city Philadelphia or any part of Philadelphia for that matter. And so it wasn't a really good setup for kids. So we really took an evidence-based approach to trying to reduce our reliance on uh, on residential care that was outside of the community for these kids. And so some of the things that we did is one of the first things we did is we educated the judges. And by the way, you educate judges, you don't train them. I'm just saying, ever working with judges, you educate them. We about the harms of the reliance on um, residential care. We we had evaluators in the courts who had to be retrained. We created um, evidence-based treatment programs for working with families in the community, and we then put a behavioral health clinician in every court, in family court in Philadelphia, to make sure that as judges were making decisions about children, they were making them with the expertise of someone who understood what the best options were for children. And here's what happened. We went from very significant number of children being placed out of state to, and if you look at this green line here, the out of state. We went from about 300 children a year to, I think there's around 10 is the number that we were there. And we were able to do that because we didn't just plop up the EBP programs in the community, but we created a whole ecosystem around that really got us the outcomes that we were looking for, which is for children used to be treated in their community with their families, because we knew from the research that that was the best strategy for working with kids. A couple of other things I'll mention, the primacy of partnership. One of the things that we were very fortunate to have in Philadelphia was some phenomenal academic partners, University of Pennsylvania being one of them. I had a faculty appointment there, and we were able to work with a lot of the researchers there, some of whom you probably know who work in the EBP implementation space. But we had multiple roles that our academic partners had. And this was actually really important for us advancing EBPs. We had people who were developers and purveyors that I mentioned some of them, like Edna Foas, for example, and Tim Beck at Penn, and others. We had folks in the academy who helped with our evaluation and research. So some of the data I'm sharing with you came directly from those partners. We had a think tank so that we had regular meetings because we had multiple groups that were working with purveyors of EBP. So there was one group working with Tim Beck and around CBT, but there were another group of people in the system working with the purveyors of DBT with Marshall Linehan. There was another group working with people who were implementing MST, or there was another group. And so all of these groups started to come together and share what we were learning, which was a real benefit to having these partnerships. We created a postdoc to train the next generation of people around real world implementation of EBPs. And some of those folks have faculty appointments now and think are doing really great work around the country. So point is, from my vantage point, the academic partnerships critical to our success as a place that was pursuing EBPs. Another lesson learned is our shift to thinking about sustainability. So the idea, a lot of where the field is today is on implementation. And I really believe we need to be thinking about not just implementation science, but we need to really shift to thinking about sustainability science. And the reason I believe that is that we actually got quite good at implementing. We're actually pretty good. And I think that, I know there are a lot of researchers around the country that have great models for implementing and so forth. But in the public system, as I mentioned earlier, if you go back to programs where you've had a successful implementation 2, 3, 4 years later, you often see that those providers are no longer providing that service because we haven't paid enough attention to the things that will sustain, not just implement those EBPs. And so we really started to make that conceptual shift that we wanted to do that. And so one of the important things that we started to do is to figure out how to sustain the practices over time. If you're doing many EBPs correctly, it costs money. It costs the provider more money, and so we started to change our financing system so that the financing system actually supported providers who took on these EBPs as one strategy for sustaining. But it's also true that we started to spend time in helping to educate consumers so they would actually ask for EBPs, right? So, if you sort of think about the black box, if we're only focused in the box, we're not thinking about, can we drive demand for these practices? So there are a whole set of things that we started to do to try to increase the sustainability of these practices over time. So this is one way of thinking about it. I think we've really been sort of here around thinking about readiness for change and how to do that and implementation. But then there are all of these areas of sustainability that we also have to pay attention to, like looking at outcomes, evaluation, scalability, um, workforce issues. Um, Learning environment. I kind of suggested that the academic partnership was really important. One of the things we did was we created something called Evidence-Based Practice and Innovation Center. Again, very important, because if a system is going to do this work, you have to then build infrastructure in the system to sustain and support that work. And we did that through our Evidence-Based Practice and Innovation Center. And as I mentioned, lots of different EBPs, but one of the things that was really cool after a period of time is we all started to learn different things. So the people who were implementing prolonged exposure in the system were learning certain lessons. The people who were working in CBT, they were learning different set of lessons. People were doing dialectical behavioral therapy, had a different set of lessons. There were, sure, a lot of commonalities, but then there were these little insights that we were able to get. And what the EPIC Center allowed us to do is to share that so that we began to standardize how we could implement across different levels of care, and almost develop a template for and game plan for how we would implement new EBPs. One of the things that you'll hear in a lot of the discussions about EBPs is that they're antithetical to cultural competence, in the same way that people talked about, they're antithetical to a recovery-oriented system of care. I don't believe that. I think that, and our experience really showed that. I would say from probably 60% of the people in the Philadelphia, somewhere probably between 50 and 60% of the people in the Philadelphia system are communities of color, Asian, African American, Latino, other immigrant communities. And so the data that I'm sharing with you, these are in many instances majority communities of color. So we know that the EBPs actually work, even if the EBPs were not demonstrated to work with certain groups. How we implemented made a difference, and so we can talk about that. But we can't assume that because something wasn't tested on a particular group, it doesn't necessarily mean that it won't be effective. And when we're talking about people who are in the public sector who often don't get the latest and greatest treatments, I think we have an obligation to make sure that we at least attempt to ensure that those folks are getting access to the best treatments, to the treatments that have the strongest evidence and science, and that we shouldn't um, deny simply because we don't have the data to say that this worked with this particular group. We should implement and then test to see, but we should also not assume that it's going to work. We need to really test that. And so, really, from my vantage point, it is cultural competence and EBPs that is the most powerful mechanism. And right now, we're in this period in our country where people are questioning whether we need to understand these differences. And we know from decades of research that you have to understand the cultural background of a community if you're going to be effective in treating that community. And you have to understand that if you're going to be doing this kind of work as well. And then I think this is my last one. I want to look to the future. And um, Dr. Lass mentioned population health in her introduction. My view about population health is this is my way of understanding. If you the population and you divide it up into people who are diagnosed, that's about 25% of the population. Then you have people who don't have a diagnosis, but they're struggling. We saw a lot of that during the pandemic. People who were just experiencing very high levels of stress. They didn't have a diagnosis, but they could have benefited from interventions from psychologists and from other mental health professionals. They had subclinical issues, and then you have people who are generally healthy. So here's what our work would look like. For people at the top part of the pyramid, what we want to do is make sure we have effective and efficient clinical care. So a lot of what I've talked about today is how do we make sure that we get the best science into the hands and into the systems that people use. That's one way that we make sure that we have effective and efficient clinical care. But we also want to make sure that for people who they don't have a diagnosis, but they're struggling, that we want to reduce risk or intervene at the earliest possible moment. And that means that we have to do early intervention screening. We have to develop new interventions for people who may not have a diagnosis but are struggling with stress. We actually do that at APA where we every year we do a survey on stress in America, and we then use that as an opportunity to talk to the nation about here are the things that you can do to reduce your stress levels. Here are the strategies that you can employ, because we know that if we can help people reduce their stress levels, it leads to all kinds of better health outcomes, not just physical health, not just mental health, but physical health as well. But here's the other thing that we have to do: we have to keep people healthy, and we have a sick care system. We pay for in this nation treating illness. We do not pay for keeping people healthy. And in fact, you ask your typical clinician, how much of your time do you spend on that? Very little, because we're all at the top of the pyramid. So, population health really is about thinking about all of these folks, implementing strategies at each one of these levels. And that is, again, where the science and evidence should be driving the interventions that we're developing. So, for example, at the bottom part of the pyramid, keeping people healthy, one of the things I always talk about when I do the talking heads things in the media is I say, look, one of the best predictors of how well we're going to do in life is social support. And if you can increase your social support, you've increased the odds that you're going to maintain your health. As one example, there are lots of things that we know as psychologists that can contribute to that. The problem is we haven't taken that knowledge and packaged it in a way that the public can use it. But if we could routinely do that and consistently do that across this entire continuum of need, we can really begin to drive down the unmet need of in the country. So that's where I think we ought to be going with EBPs, is really thinking about it from a population health standpoint and not just up here at the top part of the pyramid. So I'm ending here, and I'll just say that if the one thing that I hope you leave with, whether you decide to be on the research end of this work or on the implementation end of this work, or you're someone who's just using these practices, is to remember that EBPs are not the end. They are a means to an end. And if we can keep the focus on the individual and keep the focus on all of the ways that we can use science, research, knowledge from our field to make people's lives better, we have the best shot then of really not only implementing, sustaining, but really seeing these practices flourish. So with that, I'm going to end. And again, thank you so much for being here. And I hope I've been able to share some things that can get folks to think differently, maybe about how we do this work.
Thank you so much, Dr. Evans. That was such a wonderful presentation. Virtual round of applause. I know it's hard to see the virtual clapping, but so before we open up for questions from the audience, I'll kind of just start us off with a couple. Um, and just for the audience to know, we are recording this talk. And so if you do have a question and you don't feel comfortable having your face on YouTube, that's totally fine. You can put your question in the Q&A or chat and I'll read it aloud. But you are certainly welcome to use the raise the hand function in Zoom to ask the question yourself. So, I mean, what an amazing presentation, and it's such a nice opportunity for us to sort of come full circle in our series, because we first started our series talking about how we all need to come together and work together. And as your presentation really compellingly demonstrates, that's kind of what you did under your leadership in Philadelphia, is really bringing everyone to the table that needs to be there, and really realize this vision of a system. So that was really compelling. I'm curious, just because you have experience in other health systems, and you also have this really unique vantage as CEO of APA, what you think might be unique to Philadelphia and what can be replicated. So what are the ways in which, the kind of unique context of Philly, may be difficult to generalize, but what can sort of cut across systems in sort of improving mental health services and this kind of population health approach that you spoke about?
Yeah, it's a great question. Philadelphia is unique in a lot of ways. The one is a single payer system, so I inherited it when I got there. The system was about 1.5 billion. It's probably 2 billion now, so it's bigger than most states. So you had a lot of resources. One of the things that Pennsylvania does is that they allow their counties, and Philadelphia is both a county and a city, to manage care, the Medicaid population, and take the savings and reinvest it back into the system. So I had the good fortune of having, because we managed the care well, we were able to have those savings. It gave me the flexibility to engage a Tim Beck or a Marshall Linehan, and have the resource. So I think those things are unique. I also think that being in Philadelphia, as I mentioned, the relationship we have with Penn and other universities, Drexel, other universities. Um, uh, we had these folks down the street. We had, world-renowned researchers, at our back door. And so, being a psychologist, being a researcher myself, I saw the value in that. And I think one of the challenges is that many of the people who find themselves in leadership positions don't always recognize the real value of people in the academy and what they could bring to the table. And I really leaned into that, and I think that made a big difference. But here are the things, so those are some of the things that are unique. But I think that um, the most important thing about this work is the conceptual frame that one has about it, and that doesn't require money, right? How I think about this is different. We moved from and I'll say this, myself included, from really thinking about it's really important to do EBPs, and we got to do EBPs. That's how I started. Where I ended was I got real problems out here. There's research and science over here. What's over here that I could use to solve these problems? That is a big conceptual shift, and actually a really important one, because now I'm not implementing EBPs for EBP's sake. I'm saying I got a problem and I got enough trust in the science that's available that I'm going to look to that science to figure out how to solve those problems. That is a game changer. And I think any commissioner, any leader can make that conceptual shift, because you have the resources. The issue is, how are you going to spend the dollars? What are you going to spend the dollars on? And then that issue is an issue of political courage, because when you say I'm going to spend the dollars this way as opposed to this way, that's when you get into political battles. But I think that those battles are worth fighting if your primary purpose is to help people and to make sure that people have the best shot at life that they can, then a political leader, as I was a political appointee for 20 years between Connecticut and Philadelphia. That's what we get paid to do. And so there are differences, but I think those differences could be overcome, particularly in terms of how people think about the work.
Yeah, that's such a great response. And you kind of touched on this the uniquenesses of kind of Philadelphia's single payer system, which I think um really was kind of striking to see as a graduate student in Philly, just how much um leadership could really advance change in the system. But I think that political courage that you're talking about could be applicable in any system. You know, I hesitate to ask you too many questions about the future, but as our country faces many challenges in terms of policy and kind of investments in um, healthcare and population health, I'm sort of curious about sort of how you see the challenges ahead and sort of like where you think, our audience members as psychologists, as scientists can, as mental health professionals, can play a role in advancing this kind of beautiful vision of population health that you outlined at the end of your talk.
Yeah, I this so just to get a little background here. I've been fortunate to do a lot of different things in my career. I've been a clinician. I've obviously done research. I've done training and teaching. Done the faculty thing. Um, Mostly I've done the policy work. And through all of those experiences, I believe that the biggest challenge we have is how we think. So I almost always start my presentations with what's the mental model, because the mental model that I started with is unspoken, but it is very powerful. And one of the things that it does is it constrains how we think. So if my mental model, unspoken or not, is the way we help people is for people to come from me treat them, and then discharge them. If that is the only way that I can help people, I am locked into a very small set of ways of helping people. But if I kind of flip that again and say, look, my goal is, in my role as a psychologist, is not to just treat people. My goal is to help people have the kind of life that they want to have. Obviously, to get there, you got to address their challenges. But when you put the focus on the individual, then it begins to open up all kinds of ways that you can help people. So if you took that pyramid that I showed you earlier, you take any part of that pyramid. If my goal is ultimately to have everyone in the community to be healthy, well, that means that if I'm in the middle part of the pyramid, one of the things I might want to do is I might want to have strategies for inoculating people against trauma, as an example, right? And actually, as psychologists, we actually know some ways to do that, right? But we don't do it because we're so focused on treating people after they are ill. I use the example of ways that we know from psychological research how we can keep people healthy. I mean, there's a lot of stuff that we know about interventions and things that help people to have good psychological health. The problem is because our healthcare system is designed to treat illness, that we don't use the other parts of the knowledge base that we have. And so I think if we can get people to start thinking differently, that our role isn't to just deliver an intervention, our role is to help our communities be psychologically healthy, and I'm going to use knowledge from our field to do that, then it opens up all kinds of ways that we can do that. And from one of the things we did in Philadelphia, you were in Philadelphia, you saw the mural arts. So if you go to Philadelphia, you see murals all over the city. But we actually work with them to help reduce stigma because those murals are painted by the community. So it just opens up our thinking and our creativity, that often gets smashed when we go through our educational system. Uh, but if we can sort of open up our minds to use all of the knowledge that we have in creative ways, there are all kinds of things that we can do to help people.
Yeah, and I think your findings on giving people housing were just so compelling. And I loved I wanted to like clap or snap when you were talking about like the problem with homelessness is that people don't have a home, because I think like some of this, the solutions that we have are actually quite simple. They're just really, you know, difficult to implement from a policy perspective, but they're not particularly like brilliant insights. So thank you for that. I see some questions kind of funneling in, and so I'd love to read some of them and invite folks to um, ask their questions as well. Um, so one of the questions, well, first of all, we got lots of love from people who worked in Philadelphia and are thanking you for your wonderful presentation. We also have a question. Could you please share more about your experience transitioning from academia to roles in public mental health? I'm still early in my training, so I'm curious about any advice you have for graduate students who might want to collaborate with public mental health systems or eventually work in them.
Love the question. I would say don't transition. Uh, I, actually, this is the first time in my career I've not had an academic appointment, and I did that primarily because at APA we accredit a lot of academic institutions, so I didn't want anyone to think the APA is in some way biased. But I have always had my foot in academia. When I was in Connecticut, I was at Yale, and in Pennsylvania was at the University of Pennsylvania. And in fact, in both places, I created postdocs because what I wanted to do is, I think that the work in public policy is just so incredible. I mean, I can't even describe how fulfilling it is to be in a position as a psychologist and have the ability to shape systems based on what we know from our field to make people's lives better. I mean, I just can't think of anything better than that I could have done in my career. But when in doing that work, I always had one foot in academia because I really value, what the academy can bring to these really complex problems, and what our training as psychologists can do to translate that knowledge into real world problems. So I would say, don't transition. Think more about how do you live in both worlds. And I'm going to make the argument that even if you decide to be primarily a researcher, that you got to have your foot in the real world. Because I see stuff all the time that's just not relevant. I read it and it's like, okay, this person clearly does not know how the real world operates, right? So and the folks that I had a chance to work with Penn were just phenomenal because they were really good. I mean, one of the good friends who unfortunately passed away um, during the pandemic, not because of the pandemic, but Trevor Hadley, who was at Penn, it was just kind of the to me the quintessential, scholar, because he was like really good academically, but he was really good at understanding the systems, and I think those two roles really reinforce each other. So I would really say that regardless of where you decide to be, keep one foot in academia, keep one in sort of real world settings, because the two really should be influencing each other.
Wonderful. We have another question from an audience member. I'm curious as to your perspective on EBP implementation when barriers are political and financial, and how to continue EBP implementation at each point in the pyramid of population health in a system facing significant budgetary constraints and research cuts.
Oh wow, there's a lot of good stuff in there. So I'm gonna make a comment that you probably wouldn't expect from me, but if I'm being authentic, I have to say this. For me, there's a part of the work that is spiritual, that a part of the work that is more than the work itself. It is what I believe of what I was put on this earth to do, right? And for me, that is a driver. I worked as a political appointee for 20 years, both in Connecticut and then in Philadelphia. And most people who work in those environments many people in those environments are risk averse. Because when you're a political appointee, you have no job security. Literally, if the mayor or governor can just say, "Look, I don't want you to work for me anymore," and you're out, right? And so what that does is then it puts people who have power in positions who won't use it because they're trying to play it safe, right? For me, um, I am impatient for change. I see the problems and inequities in the way our healthcare system works. I am highly motivated to try to change that. And so for me, I was okay with taking risks, and I took a lot of risks, right? A lot of things that I did, I kept seeing, I actually would write the headlines in the newspaper when I would make a decision. I would like, okay, this is how this headline might look, and then I try to figure out how to avoid that headline being written, but I wouldn't back away from the commitment. So I think that if any of the folks here are interested in working in public policy, I would strongly encourage you not to go into it if you're going to be timid and maintain the status quo. We don't need folks like that. We need folks who are going to take their training and then actually do something that will make a difference for people who nobody really pays attention to, right? So people are homeless, it's easy, for a system to kind of ignore those challenges because they don't vote, and there's a lot of reasons that you can kind of get away with it. So that's number one. I think go into the work because you have this greater view about what can be done, and that you are an instrument to make that happen. Number one. Number two, I think that having conceptual clarity about what it is that you're trying to do is really important. And what I used to see all the time in government, especially, people would just do stuff, right? They would do things, and it made them feel good. But then I was like, well, like, why are you doing it? Well, like, what's the end point? What are you trying to really accomplish? And is there consistency between what you're doing over here and what you're doing over here? Or are you just sort of reacting to, things that are in the environment? And because we were really clear in Philadelphia, same in Connecticut, that what we were trying to do is to have a psychologically healthy community. um, we were able to keep the focus on the right thing. And so as we were thinking about, what are the strategies to reduce stigma in the community? What are the strategies to reach people earlier? What are the strategies to make sure people got the best care? What are the strategies, going across that continuum, um, being clear about what the outcome is really opened up the possibilities. And again, people have to be willing to draw outside of the box, draw outside of the lines in order to solve some of these problems. If we continue to do the same things that we've always done, we'll get the same results. And if we're going to get different results, we have to be willing to try new things. And I think that's where a lot of the barriers come in, is that people like, we can't do that. I'll just give you one example. I mentioned the mural arts program. People, when I first did that, it was 2007, 2008. You know what was happening in 2007, 2008? We had an economic downturn. It would have been really easy for a reporter to say, the commissioner of behavioral health, with all of these mental health problems we have, is using money to paint murals in the city. Now, that would not be what we were doing. What we were doing was using art to engage communities that would never come to our regular treatment programs in a creative way, so that we can begin reducing stigma, because we knew that we could create the best programs in the world, but if no one ever came to the programs, what use was it, right? So if my goal is to try to help as many people as possible, even though that was a high risk strategy at the time. Now it's not. We literally have people from all over the world come to Philadelphia to kind of look at that. But at the time, it was high risk because nobody had done it before. But if you're not willing to do that, then you're going to miss some opportunities to help people who could otherwise be helped.
What a wonderful response. And yes, those murals are really gorgeous and sort of paint the Philadelphia landscape. So I think we have time for one last question, which I see is in the chat. And it is, do you have any advice for psychologists working exclusively in service provision in large community mental health organizations, i.e. some autonomy, no control, to support or push for greater penetration of EBPs? I do a lot of consultation, talks for clinicians, advocacy with management, et cetera, but would be really interested in other ideas.
I would start with problem solving. Um, the way, it's like what I was talking about at the end. I think if you're in a program like that, you could certainly go and say, I think we need to do more EBPs. And, if kind of depending on who the program director or CEO is, they might or might not be responsive to that. But if you can go and say, look, we have a real problem with, name it, engaging adolescents. It's an adolescent treatment program. And, there's this really great research on stages of change. And I think if we can change some of our practices based on this, we can engage a lot more of these youth, right? That's a different conversation than let's do more EBPs. And I think if you can kind of really think through what are the challenges that people are facing and how can we solve those using these strategies, that's always going to be a much more effective strategy than getting people to sort of buy into EBPs. Although, again, if you were talking to me, I'd be like, yeah, I'm into it, but I'm different. I'm a psychologist. And most of these people are not psychologists who are running these programs, by the way.
Well, that's a great way to end with just sort of thinking about and being clear on sort of where we need to be and the challenges that we face. So I just want to give a big round of virtual applause again to Dr. Evans. Thank you so much for sharing your incredible experience and expertise with our audience. And I know there are lots of trainees in the audience who are looking at you as a role model for their careers. So thank you again. We're so lucky to have you.